Welcome everyone, and this evening's from WCH, our first one, so thank you for inviting us to the organising committee. And first we acknowledge the traditional custodians of the land, the Kaurna people, and pay respect to the elders past, present and emerging. The first speaker this evening is Associate Professor Alexia Pena, who is going to present some of the research gaps in polycystic ovary syndrome, one of her research focuses. And if you have any questions, you can just put them into Q&A like you normally do, and we'll go through those at the end. Thanks. Over to you, Alexia.
Okay, thank you, Jenny, and thank you everyone for joining today's mini reviews and for the invitation. So I'm going to talk about polycystic ovary syndrome in adolescents, and the main difference that we need to understand for adolescents is that there are two criteria: irregular menstrual cycles, well defined, plus hyperandrogenism. That means severe acne or hirsutism, plus high androgen levels. And importantly, in adolescents, we should not be using the pelvic ultrasound to look at polycystic ovarian morphology, as it is not recommended in this age. Given that broad definition, I'm just going to get into what the international adolescent guidelines have been over the years. And I was very fortunate to participate in the international evidence-based guidelines, as well as two international consortium on adolescent PCOS. These guidelines, the first ones started in 2016, and the recommendations were published in 2018, and we published the adolescent recommendations in 2020. But we are working on update on the guidelines and hoping the update will be finalized next year. So what are the research gaps in adolescence? So we know that many women with PCOS have a delayed diagnosis after seeing multiple healthcare professionals and impacting on the physical and emotional well-being. And in fact, women have experienced poor diagnostic experience. Within adolescents, there were no studies evaluating their experience. So to address this gap, we conducted a cross-sectional study of adolescents with PCOS. This study included 86 children, 34 from the Women's and Children's, 52 online, with a mean age of 16 years. We did have a good representation from rural and city background adolescent girls. Mostly they were from Australia. There was some from UK because the survey was conducted online, it was in UK. From these studies, we found that the time till diagnosis was not as long in adolescents comparing to adult women. So majority of them were diagnosed within 6 months to a year, comparing to adults that are diagnosed more than 2 years. And the majority are seeing 1 to 2 health professionals before the diagnosis is made. The other important thing we look into these studies, how satisfied were they with the information provided after diagnosis, and whilst they were satisfied for the lifestyle and medical therapy, the long-term complications and emotional support was an area where they were not satisfied or the information was not mentioned. When we asked them about what were the 4 important features for PCOS that were most important for them, the irregular menstrual cycles and difficulties losing weight were the most important for them. Whilst anxiety was not as high there, and of course infertility at this age compared to adult women was not out there. So other gaps in adolescent PCOS is that a lot of studies looking into metabolic comorbidities, insulin-resistant dyslipidemia, reproductive abnormalities in women, but there is limited research in psychological comorbidities of adolescents or general women with PCOS. So adult women with PCOS, anxiety and depressive symptoms are less likely to engage the treatment. So we are conducting at the moment a cross-sectional study evaluating the depression, anxiety and stress score, as well as quality of life. We have so far 60 adolescents with PCOS, and on the left you will see a copy of a depression anxiety score questionnaire. Most of the answers are in the moderate to severe area, 2 or 3. So 30 out of 60 women had moderate depression, 37 to 60 moderate to severe anxiety, 19 over 60 moderate to severe stress. But what are we doing about this? So we are currently conducting a randomized controlled trial over 8 weeks, evaluating meditation to improve emotional well-being in adolescents with PCOS. So we either randomize them to have transcendental meditation twice a day that is properly trained in a standardized way, or they have a healthy education lifestyle that is followed by sitting quietly for 15 minutes twice a day. That might be reading. They get assessments before and after the 8 weeks. The study has 5 subjects to finish and hopefully have results towards the end of the year. But similarly, in other places, they're looking into other alternatives to improve mental health and well-being in adolescents with PCOS. And these positive outcomes from a mindfulness-based healthy lifestyle intervention for adolescents and young adults with PCOS. Another important thing to consider is in PCOS is the diagnosis is according to menarche, at least for the irregularity in menstrual periods. So in the first year of menarche, we're unable to diagnose PCOS, but between the first and 3 years, we need to take into account certain menstrual cycle irregularity, either less than 21 or higher than 45 days, plus the hyperandrogenism. And after 3 years, they might be in the same criteria as adults. But the most important thing for adolescents is that we do not use pelvic ultrasound for diagnosis of PCOS. So how about other markers? Can markers such as anti-Müllerian hormone can help? And when we review the evidence for the guidelines, that required as said that should not be used as a single test. And the evidence was derived back then for 6 studies in adolescents. Recently, there have been further studies published supporting the AMH as an adjunct to evaluate PCOS in adolescents. And as a reminder, the anti-Müllerian hormone is produced from the granulosa cells in the ovaries, and it is produced in 2 different forms. So you had either the pro-AMH, the AMH itself that acts on the receptor, the total AMH. So you can evaluate different types of AMH or pro-AMH to see if there was any difference. And we did that in collaboration with Michael Pahertz in New Zealand. We're looking to pro-AMH, total AMH in adolescents without PCOS and with PCOS. And you're looking here in blue are the controls, in purple are the adolescents with PCOS. We look total AMH at the top and pro-AMH at the top 2 figures. And in the bottom figures, we got API, which is the pro-AMH over total AMH, and the difference of this one according to pivotal stage, and there were no significant difference across these populations. So meaning that at least as a single marker, even the pro-anti-Müllerian hormone and total anti-Müllerian hormone are not ideal for evaluation of polycystic ovary syndrome in adolescents at itself. So as a take-home message, the current information provided at diagnosis of PCOS is not meeting adolescent needs. So we need more education to different clinics and to help providers to improve what we're giving at the time of diagnosis to adolescents, especially because they are a time of transition from care from adolescent to adult healthcare providers. The adolescents with PCOS have higher levels of depression and anxiety that needs to be addressed through improved adherence to treatments. And further research is required in diagnosis and follow-up of adolescents at risk, because some of them might not have the full criteria, but they eventually develop polycystic ovary syndrome. And AMH, anti-Müllerian hormone, might be useful, but not alone, because we still need to consider the other 2 criteria, irregular menstrual cycles and the hyperandrogenism, either clinical acne or excess hair, hirsutism, and or levels of androgens, testosterone. So I would not finish without acknowledgement Professor Helena Tiddy and Rod Norman, who were part of the CRE in PCOS to develop the guidelines, colleagues in the clinic, adolescent gynae endocrine clinic at the Women's and Children's, and collaborators in Otago. Thank you very much.
Thank you, Alexia. Nothing in Q&A box at the moment. I'll just keep that open in case anybody's got some questions they want to add. Perhaps I could just start one off. I think it's really interesting, the work with the meditation. And I'm just thinking, I realize that the outcome for this study is mood, because you have to have some defined, relatively short outcome. But if it's effective, would you consider sort of extending it on to looking at the outcome of actual polycystic ovary syndrome, the actual treatment you might expect to be more effective in things like weight and other measures of androgens if the meditation is successful for mood?
That will be interesting. Mine required a little bit of a larger sample size. We are measuring though, and I didn't mention in the briefing presentation, we are measuring salivary cortisol 3 times a day. So before breakfast, after breakfast, and midnight, and getting those average before and after. So at least we got a more objective measurement of mood and stress in these adolescents. But yes, good point. We wish to have other markers. We are measuring them, but I don't think we'll have the power for it.
No, very interesting. It's huge. Could apply to lots of other conditions too, I think, if it's effective. You know, it's very exciting. A tough study to do. So this is the developmental origins of type 1 diabetes, the ENDIA study. And there's been quite a lot of initiatives in the screening and prevention space in Australia, some quite recent, and units involved in all of these. But today, just to concentrate on the ENDIA study. So we recognise that children are born with a genetic risk for type 1 diabetes. Then there's an immune activation and response stage. And then once they've developed 2 or more islet antibodies, we call that stage 1 type 1 diabetes, and I'll explain why that is shortly. And then they proceed through the second stage where they get occasional raised blood glucose levels through to what we recognise as the clinical diagnosis of type 1 diabetes, at so-called stage 3. What's important is these islet antibodies appear very early in life, and they peak very early as well in at-risk children. And once you've got multiple islet antibodies, it's a pretty robust surrogate, because 85% of children then go on to develop type 1 diabetes in their life once they've got 2 or more islet antibodies, unlike just the single, which is shown in the green, which is only about a 15% risk. So with this in mind, and the fact that it's occurring pretty early in life, we set up the first, and indeed the only, at-risk cohort following children from pregnancy. There are birth cohorts, but not pregnancy birth cohorts. And the children are at risk because there's a family member with type 1 diabetes, either their mother, father, or brother or sister at home. And proposing that multiple environmental exposures in early life from the pregnancy onwards interact by the omic systems to increase the penetrance of the risk genes for type 1 diabetes. And there's quite extensive sampling across the child, the mother, the father, and the sibling if they're the proband. And this is initially in each trimester, then 3 monthly, then 6 monthly until 10 years of age, or until the child, if they develop type 1 diabetes, exits the study. And we have a biobank, and then these samples are supported by questionnaires across nutrition in pregnancy and infancy and the second year of life, and general health questionnaires, and exercise, lifestyle, and other questionnaires. And we started off with about 55% of children coming into the study who were approached from eligible families. So these were primarily pregnant mothers. And we have 1,473 of the 1,500 odd that were brought in remaining. And not surprisingly, the proband is most commonly the mother, almost 2/3, father, sibling, and the children are just almost 5 years of age on median. The oldest is almost 10. And primary outcome is persistent autoimmunity. And you can see that children develop at this young age, they're often multiple. So that stage which will progress to type 1 diabetes very likely. And like in USA and Europe, the first antibody we see is the insulin antibodies, and then the combination of GAD and insulin, and then GAD alone. And we've got this later rise of the zinc transporter 8 antibodies, which we find quite interesting because they appear not to impart quite the same risk as insulin and GAD. So these are some of our key investigation areas. First of all, obviously, we want to look at the determinants of autoimmunity. It's really what ENDIA is all about. These children are also at risk, of course, of celiac autoimmunity, and that's another arm of the study. Of all the work looking at exposures, we're really left with the stronger evidence in the environment that is increasing the risk of childhood type 1 diabetes, being with viral infections, both respiratory and gut, and also excessive weight gain in childhood, and also appearing that reducing the microbiota that produce short-chain fatty acids is also a driver. And for our work in ENDIA, we've sort of got a bit of a plan, I guess, over the next few years. We've already started an ESTA case control study looking at determinants for autoimmunity at this stage. And then we have some total cohort studies for things like nutrition and growth effects and genomics. And then we're planning a case cohort design when we've got over 100 cases of autoimmunity persistently. And for our ESTA case control study, this is really we lead it from South Australia, but it's very much a national work. We have laboratories in New South Wales, Queensland, and Victoria, and South Australia involved, and quite a few international laboratories as well. And indeed, the genetics is done in Western Australia. So it's a pretty around the country effort with quite a lot of collaborations. Now, because almost 2/3 of the mothers have type 1 diabetes, it's obviously an opportunity to look at the impact of type 1 diabetes in pregnancy. We've done a bit of work in this. In the WeHi have looked at the microbiome in pregnancy and shown that the distinct functional changes using metagenomic sequencing, in that mothers with type 1 diabetes have a more pro-inflammatory microbiome, so they're making less butyrate, which is not surprising, but it was quite a dramatic difference, and this was the first time this has been shown. This is work from Alexandra Ross-Schultz at WeHi. And this is interesting because there's a fascinating phenomenon whereby if your mother has type 1 diabetes, your risk is quite a lot lower than if your father has, and you have an intermediate risk if your sibling has type 1 diabetes. So this so-called maternal protection is still not well understood. Why? It could be a differential transmission of risk genes between mothers and fathers. In India, we're looking at the maternal milieu during pregnancy because we've got that opportunity to do that. Possibly this microbiome may enhance development of innate immunity in the infant and protect them. We've also got a lot of work on the early life gut microbiome, and in collaboration with some of the Finnish cohorts that have worked in this area as well. This is work from University of New South Wales in the lab led by Bill Rawlinson and Maria Craig, and Kiwok Kim is our postdoc fellow there who's looking at the viruses in pregnancy and early life and has just finished the first look at the NESTA case control study. And we've also looked at some of the lifestyle features between women with or without type 1 diabetes. This is one of our registrars here, Maddie Hall, who looked at mental health in 800 pregnancies. It was the largest study that has been published in the area. And it showed, interestingly, that with really intensive care for women during pregnancy with type 1 diabetes in Australia that we offer here in this country, the scores for depression, both in third trimester and postnatally, and stress, both in third trimester and postnatally, were very comparable with and without type 1 diabetes. So they might have had diabetes-specific stress, but it was reassuring that their mental health was fairly robust in comparison with women without type 1 diabetes. The other area is the children without autoimmunity progressing to type 1 diabetes. We've been interested here in South Australia in the fact that children and adults who get type 1 diabetes have smaller pancreases. And this is a little 4-year-old child on the left with type 1 diabetes, and on the right, a control. And this is the area of the pancreas. You can see there's a marked difference. And we looked at a number of children in the orange. You can see on average their pancreatic area when they get type 1 diabetes is quite a lot smaller than the controls, age and gender matched controls. And we looked at their fecal elastase. This was led by Priya Augustine, one of our registrars at the time. So exocrine function, they also have normal but lower exocrine function, which goes in keeping with having a smaller pancreatic area. So the exocrine pancreas is involved in the progression to type 1 diabetes at some point. The question is when, and we looked at the first 28 progressors to type 1 diabetes in India, or stage 1 type 1 diabetes. And we showed, interestingly, that in the first couple of years of life, normally your fecal elastase levels are rising as you develop exocrine function in the pancreas as normal ontogeny. But when you actually are progressing to type 1 diabetes, that rise is blunted. These are very young children. Their islet antibodies are appearing at 1.5 years. So that progression was blunted. And it appeared that in some cases this was occurring before the development of autoimmunity, which we're looking at in more detail in larger numbers now. We're also interested in glucose monitoring in these little children as they progress. We know that long before you actually get symptomatic type 1 diabetes, you have variability in glucose levels, both upper, higher and lower. And this may be a potential marker of progression for intervention trials and surrogate markers. And this is a child of 4 who's not on insulin, and at the top there's what we would call sort of stage 2 diabetes, slightly higher blood sugars, above 10, and some slightly lower ones, so dysregulated, and then they start to progress a bit more to they're asymptomatic, they're off insulin, but they've got some higher levels after food. And this is work from Avani Haynes from Chiltern Kids in Western Australia, is one of our ENDIA investigators, and looking at continuous glucose monitoring in our children and comparing the children with autoimmunity, the cases in the pink, and you can see their variability, their standard deviation of glucose is much, much wider than the children who are matched for them for age and gender who don't have autoimmunity. And similarly, their time and range on their continuous glucose monitoring is much wider, with some children getting down below 70%. And these are children who are asymptomatic and haven't got clinical type 1 diabetes compared with the controls. So, thanks very much to our big ENDIA team. We have a marvellous project manager, Dr. Megan Pena, who's only time to really mention her in the middle there, and our participants, their wonderful families who sort of hang in there for this long follow-up observational cohort, and our funders. Thank you. Now, I'll just answer the questions. Is gestation, is from John, 2 questions. Thank you, John. Is gestational diabetes associated with autoantibodies? Normally not. You can get autoantibodies in non-type 1 diabetes. You can certainly get them in children with cystic fibrosis-related diabetes in particular, but we would normally not expect to see autoantibodies in standard gestational diabetes. A few of our participants, the mothers, have gestational diabetes, obviously, and very few have type 2, but obviously gestational diabetes is by far the commonest diabetes in normal populations, but obviously in India it's been selected for the type 1. Now, can you therapeutically target the autoantibodies to prevent the onset? So next question is, can you therapeutically target the autoantibodies to prevent the onset of diabetes? No, I think we see the need as we're really immunologically having to target the T cells, John. We see the autoantibodies more as a marker of the activity, and the reason that you presumably have this quite distinct difference in risk with multiple antibodies compared with single is that it probably is a reflection of the degree of enterolytis, which is an Apache attack on the intraproducing cells. But it's not, it seems that we have to, immunologically, the interventions all targeting the immune cells as opposed to the actual autoantibodies produced by them. As people probably aware, increasingly there are more things we can do, and since the teplizumab study, which came out in 2019, we're sort of seeing that there's been a big boost in that area around either side of COVID in terms of immune trials becoming more available. Thank you.